Hi, welcome to another episode of Talking with Docs. I'm Dr. Brad Winning.
And I'm Dr. Paul Zalzal.
And I'm Dr. Heather Badalato.
Dr. Badalato, tell us a bit about yourself.
Well, I previously worked as an addiction medicine physician for 10 years. I did my fellowship at the Center for Addiction and Mental Health in Toronto and worked at Homewood. And then I got my extra year of competency through the college. So, yeah.
So you have a very unique set of skills and experiences that make you a very useful resource for our viewers.
Yeah.
Thank you.
Yeah, you're welcome. Thanks for being here.
And what are you going to talk about today?
Well, I thought we'd just do a quick sort of overview of what opiate use disorder is, what are the signs and symptoms of it, and what people can do about it. It's a very big topic, so we'll just try and condense it into a short talk for today, just a general overview.
Okay, so you used opioid use, what was that?
Opiate use disorder.
As opposed to the word addiction. Can you just quickly, in one sentence, 2 sentences, or 10 sentences, tell us the difference between those two, opioid use disorder and addiction?
Well, it's mainly just semantics, because opiate use disorder is a spectrum. It's the new criteria in the DSM, which is what we use to diagnose psychiatric disorders. So it used to be that it was abuse and dependence, and addiction was kind of associated more with dependence. Now, opiate use disorder kind of explains the spectrum more. There can be milder forms of abuse, and then you're getting into opiate use disorder that's severe, where it's basically taken over the person's life and they meet a lot more criteria. So it's the important thing is there a problem, and is it taking over your life, and can you function? That's basically the most important thing, and how severe is it?
Okay, excellent. Now, if someone has an addictive personality, does that mean they're easily addicted to things, or does that mean everyone wants to be around them all the time?
Probably more of the first thing you said.
But
yeah, that's another term that doesn't really have any, it's not really in the DSM, but there are people that are more prone to addiction, and there is a strong genetic component to it. So a lot of people have relatives who had problems with addiction, can be more at risk. Doesn't mean they will be addicted or have a substance use disorder, but it means they're just more at risk.
Okay. But people do like being around you, Paul.
See? It is an important topic right now, because opioid use and abuse is at an all-time high right now.
Yep.
We know that. We're trying to alter the way we treat postoperative pain because of this global problem right now. So a really important topic to discuss. So let us know about it.
So opiate use disorder has, there's a bunch of criteria that you sort of have to look at. So when someone is misusing opiates or starting to get into trouble with them, it starts to affect lots of different areas of their life. So, if you find yourself spending a lot of time using, recovering from, or obtaining drugs, like thinking about it a lot, how am I going to get my next dose? That's part of it. Using more than you wanted to, tried to cut down a bunch of times, or you say, oh, I'm only going to take 2 pills today. And it's really hard to stick to that, or you're fighting it all day. Those can kind of be some signs of, you're kind of getting into trouble, or using in serious, physically hazardous situations. Other things can be if you're using despite having a medical or psych condition that's being made worse by opiates, where you continue to use even though you've had health consequences or psychiatric consequences, you can't stop. So there's a good way to summarize, there's 3 C's. Cravings, where you're thinking about it a lot. Consequences of your use, like you may have lost relationships or problems with your job or legal problems. And control, where you just don't have control over your use. You're using more, you're spending lots of money trying to get, and it's causing, again, financial consequences. Those are just some of the things that start to happen.
Okay, cravings, consequences, control.
That's just an easy way to remember those. Yeah.
Analogous to clarity, cost, and carrots. That's a diamond.
Okay.
All right, so
you heard it here.
So this is now you may be wondering if you're if you have an opiate abuse problem, or if someone you know, and here's one good way to look at it, and just repeat the three things. So like you're around someone, you're thinking, oh, do I have an issue with this, or does my partner have an issue with this, or someone I know? The things to look for are, again, one more time, the 3 C's.
So cravings, consequences, and control. That's just a really easy way to remember. Look at those 3 areas. And
Okay.
if you're kind of checking all the boxes in all 3 areas, it's time to at least look at getting some feedback or help or from a medical professional.
And I think that's whether you're a kid at university, whether you're someone who's post-op from a total hip replacement, whether you're someone that's had a previous addiction problem in the past and maybe you've relapsed. So these people or these patients are from all different walks of life. It doesn't, I think we all have a stereotypical idea of what we think someone that has an abuse problem looks like, but really it could be anybody, anywhere, in any walk of life.
Okay, and we work a lot in the gray area because we prescribe a lot of opioids right now until there's a better alternative, which I'm involved with a lot of research in that area, and a lot of people are involved in a lot of research for trying to control post-operative pain without the use of opioids. However, right now we prescribe a lot of opioids. So in that time period after a surgical procedure where you need some kind of pain control, can it be difficult to distinguish, am I becoming dependent on this, or am I, because there is a consequence, there is a craving for it, and you notice it if you don't take your opioid, if you just had surgery yesterday.
Right.
How do you distinguish in that gray area when it's therapeutic and when it's pathologic?
So there's usually and a lot of times the criteria is over time. Like it doesn't, it's
Okay.
really too short. If you get a prescription for, post-op pain needs to be treated. That's appropriate. You just had surgery. The recommendations are to minimize the risk of developing an opiate use disorder is to prescribe small amounts, for as little time as possible. Because what happens a lot of time or in the past is patients would be given a large prescription or whatever, and then they'd take it even when they didn't need it, and then they'd kind of end up in trouble. So if you find yourself, really having trouble cutting back when you don't need it anymore, or you're taking more pills than what's prescribed, or if you're altering the way it's supposed to be taken, like chewing it or anything like that, like altering the route of administration by any means, like that's when you sort of have to say, there's a problem.
What's your time frame for arthroplasty? What do you feel comfortable?
I mean, how long do I want them on it?
Yeah.
For me, there's not a specific number. I always tell my patients I want them to be going down every week.
Okay.
So the rate at which people reduce their use is very variable, depending on the procedure they had, their tolerance for pain, the pain they had before. So there's so many, if they were taking before surgery too. So for me, I don't have a specific number, because a lot of people say, well, listen, I'm nervous about this. I'm like, okay, well, we need to control your pain. As long as, every day you're not going up and it's slowly going down, I think then I'm comfortable. But yeah, I mean, by 3 months, I want them off it, and most of it you should be off most of it by 6 weeks, to be honest with you, especially for knees.
Yeah, I'm 2 weeks, 6 weeks. 2 weeks, for the first 2 weeks, you're going to need it, you're going to use it. And then 2 weeks to 6 weeks, you got to start tapering down off of it. And then after 6 weeks, if someone says, oh, I need another prescription for my painkillers, then I'm like, well, is something wrong with the procedure? Is there an infection or something going on there, or a fracture? Or is there a problem with the use of these opiates? So I'm very reluctant after 6 weeks to encourage continued use. Those are just my sort of guidelines personally.
And I try to get rid of the narcotics and increase the over-the-counter stuff. So more acetaminophen, more ibuprofen if that's safe for you, or whatever.
Yeah, it's just
more ice.
It's always going to be dependent on what the procedure is and the patient. So the whole thing about opiates is, again, watching for if you're we always used to call it borrowing from tomorrow to pay for today. So basically, if a patient's like, oh, well, or they're coming for early refills or running out faster than what you would prescribe, those are sort of red flags that you want to have that conversation about what's going on, how can we help.
And usually the size of my script will go down, as well as in Canada, we can't do refills for narcotics anymore. We used to, I think, be able to do that. So that's another safeguard put in place. Or the pharmacist often will reach out and say, listen, just so you know, this person got a prescription from their family doctor, and now they're asking for one from you. So that would be another sign, I guess, if they're double or triple doctoring. But now there's a registry where I think that's all captured by a computer to say, listen, this person's already got a bunch of narcotics and they should not need more. So
there's a narcotic monitoring system that is at the pharmacy, and the pharmacist can see if they have other prescriptions, and they can notify.
Okay, so now we've empowered you to help detect if you're developing a disorder, or if someone you know is. Have you ever tried? Have you ever taken an opioid?
I think, to be honest, I took Tylenol 3 once when I had severe strep till I couldn't even swallow, and it was at home, and I took one, and I felt really odd, to be honest with you.
Yeah,
not good.
I was prescribed it after a certain procedure in a tender area, and I did take it, but it did help with the pain control, that's for sure.
Yeah.
But then, once once I didn't need it anymore, you transition to a non-opioid.
And I think that's probably the other fallacy, is that people don't necessarily take these to feel good. It's sometimes they take them to not feel bad, kind of thing. It's not you're getting high or you're happy or whatever. Often it's just to avoid the pain or to avoid the symptoms of withdrawal.
Right. So that's what it's actually a good segue to talk about like tolerance, and because that's initially when you take an opiate and you're naive to it, you're gonna, you might feel that euphoria, but as over time, as your body gets used to it, what happens is you often need more to get that same effect. And then when people are really struggling with opiate use disorder, they're taking the opiate just to feel good, like their brain is kind of switched and they feel normal with it and they feel terrible without it. So they're trying to just get rid of those negative physical feelings and emotions by taking the opiate to feel normal. And that's where that switch happens.
Excellent summary. Thank you so much.
Just last little piece. So if we do think that we have a problem or someone we have has a problem, what should we do?
So it's important to go to your physician, or you can also go to, there's lots of opiate clinics that are out there that can help replace, if you're really struggling with opiates, they'll replace your opiate with a safer opiate that's a longer acting, like Suboxone or methadone. There are implantable or injectable ones that can last quite a long time. So we're really evolving, so you don't have to go to the pharmacy every day. That's a whole other talk in itself, but those are options. One thing we do not recommend is straight detox. Going to a detox without an intensive treatment program. If a patient's dependent and they go to a detox, their relapse rate is extremely high, and most time that's when you're at risk of overdose because you've lost your tolerance. So a lot of times, unfortunately, I've seen many overdoses happen shortly after patients left detox or treatment. So that's why we strongly we actually refused at one point to detox patients without a plan. Yes, because it leads to overdose situations.
That's going to be a next video we're going to do on how to deal with this, how to treat this.
Okay.
Which you have a lot of expertise in. Thank you.
Thanks, Dr. Badalato, for sharing.
Thank you very much.
So now we just want to empower people. We want the stigma to go away. We want people to be safe. So if you like this video, please like it, subscribe to our channel.
You know what? And share this with your friends or anyone you're worried about or not worried about, or anyone who has kids that they're worried about. Just share it, and hopefully we can help some people with this video. Remember, you are in charge of your own health.
We'll see you next time.